Hello, my name is Donna Bishop, and on behalf of CAMH, thank you so much for joining us today for the webinar, Breaking the Silence, Men's Mental Health, Stigma, and Support. Maybe you're here for a loved one, maybe you're seeking support and clarity for yourself. Whatever brings you here today, you are in the right place. Excuse me. There's just a few housekeeping things before we begin. There's a couple of communications tools I'd like to draw your attention to. The chat function is a public forum that you can use to interact with everyone who's on the webinar today in real time. The Ask a Question is a private forum where you can pop a question in at any time. Maybe you came with something already that you wanted to ask. Maybe something inspires you throughout the webinar. Regardless, please use that whenever the inspiration comes to you. While we aren't able to provide personal medical advice or diagnoses today, we certainly will speak to common themes and share guidance whenever possible. And these conversations always benefit by your participation. So thanks so much. If you would like captions while we do the webinar, there is also a captions button just below the video player for you to activate that. And yes, we will be recording this and you will receive a link. As we come together from many different places today, we want to take a moment to acknowledge the land on which CAMH operates. Even though we're not physically gathered there today, it remains our responsibility to honor its history and significance. We acknowledge that CAMH is situated on lands that have been occupied by First Nations for millennia, lands rich in civilizations with deep knowledge of medicine, architecture, technology, and extensive trade routes throughout the Americas. In 1860, the site of CAMH appeared in the Colonial Records Office of the British Crown as the council grounds for the Mississaugas of the New Credit, as they were known at the time. Today, Toronto is covered by the Toronto Purchase, Treaty Number 13 of 1805 with the Mississaugas of the Credit. This vibrant city is now home to a vast diversity of First Nations, Inuit, and Métis people who enrich our community immeasurably. CAMH is deeply committed to reconciliation. We honor this land through programs and spaces that reflect and respect its heritage, and we embrace the healing tradition of the ancestors, weaving them thoughtfully into our caring practices. We commit to building meaningful relationships and partnerships with First Nations, Inuit, and Métis people, sharing this land and protecting it for generations to come. It is my pleasure to introduce Dr. Omair Husain. Dr. Husain is the Associate Scientific Director and the Medical Head of the Slate Family Center for Youth in Transition here at CAMH. His primary research interests include schizophrenia research and suicide prevention, with a particular focus on improving access to appropriate mental health care for ethnic minorities in high-income countries and addressing the significant mental health treatment gap in low and middle income countries. His work also includes public engagement initiatives with a focus on reducing stigma through the mediums of art and film. So interesting. Clinically, Dr. Husain provides inpatient care in the early psychosis unit at CAMH and also works in the CAMH emergency department. Relevant to today, he is currently working with other clinicians and scientists at CAMH on an initiative that focuses on men's mental health. Welcome, Dr. Husain. You are clearly a very busy guy, so thank you so much for taking the time to join us in this webinar today.
For the conversation.
So I want to acknowledge off the top that we are talking about a very nuanced topic when it comes to men's mental health. And while we'll inevitably make some generalizations during the webinar today, for today's purposes, like this is not a simple subject, but tell us about mental health when it comes to men.
Yeah. I wonder if just scaling back a little bit, Donna, and speaking about mental health more broadly within the Canadian context might be a good starting point.
Let's.
I think rightfully so, over the past several years, we've been having more dialogue about the state of affairs as they relate to mental health for the Canadian population. And I think it's important to note that in any point in time, 1 in 5 Canadians have a diagnosable mental health condition. Suicide remains the second leading cause of death for young people. And a lot of the conditions that face our whole younger adult and adult populations, they start in youth and young adulthood and cause disability throughout the lifespan. So mental health is a key issue at a population level. We
Mhm.
know that different segments of our population have variations in their vulnerability. So when it comes to men and the focus of the conversation today, it's particularly related to the burden that is facing men as it relates to fatal outcomes and mortality indices of mental health. And for reference, what I'll say is that when it comes to the recent statistics, overdose deaths have more than doubled from 2019 to 2021, and men account for more than 70% of overdose deaths. When it comes to opioid-related deaths, there's been a ton of attention about the opioid crisis facing North America, Canada specifically. These represent 1 in 3 deaths of Canadians between the ages of 19 and 40. These are young people at the most productive stages of their life, and there's a huge overrepresentation in men. I mentioned suicide. The rates of suicide have probably plateaued from late 2007 up until now, but men still account for 3/4 of suicide-related deaths. And as I said, these are claiming the lives of young people on a daily basis, and suicide is the second leading cause of death in young people in Canada and North America more broadly. So I think grounding the conversation in some of these stark and alarming statistics is important. These statistics are what have drawn to attention to people myself, a frontline physician with administrative roles, policymakers, that maybe our services as they're laid out are not meeting the needs of our population. We're not meeting men where they are. They're not accessing care. And do we need to rethink our policies and our strategies in trying to improve mental health outcomes and addressing what we know are very treatable conditions to help to prevent these catastrophic outcomes that I'm referring to?
Wow, that is a lot to take in, and there's so many nuances and explanations within there. But it strikes me that there are kind of two paths of understanding that we can zone in on today. And one is the barrier to men accessing the care and support that's there. And two, looking at when illness symptoms present. And I'm wondering if maybe we start with the latter and then we can move into the barriers.
Yeah, that sounds great. From my clinical roles, I work within the Slate Family Center for Youth in Transition. We are an early intervention for psychosis program. So a lot of my ethos as it comes to mental health is grounded in trying to recognize things as early as possible so that we can intervene and prevent the progression to more severe outcomes. So recognizing mental health distress within men more broadly is something that's incredibly important, but actually quite complex because socialized norms and how I think we've adhered to gendered norms as men within the population really impact the way that distress manifests, how illnesses show themselves. And stereotypically, men have been socialized to operate from a stance of self-reliance,
Hmm.
sometimes conceiving that seeking help is a sign of weakness. We're supposed to be stoic. Get on with it. Just deal with your issues. Let's not moan or complain about it. Just kind of move forward. And I think that ethos, um, that impact on the psyche really is a barrier to access to care, and it needs to be addressed. Even if we start to think about that through the lens of our diagnostic tools as a psychiatrist, I don't think we always realize that men are probably presenting in a slightly different way with how they show their distress, their mental health symptomatology, to the way that we understand them through our diagnostic tools. So typically, men will externalize their distress, and that may show itself with irritability, agitation, the use of substances, risk-taking behaviors, or social withdrawal. And those are not the typical features that we understand or recognize through our diagnostic tools, where we're looking for things like sadness, anxiety, distress in the same way that maybe women are more likely to present with it. So detecting the early signs can be complex, but looking for atypical features may be the way that we start to catch things a little bit early. What I
And
will
I'm,
say, sorry, what I
no,
will
go ahead.
say is that alcohol use is a very problematic issue, particularly for men. The prevalence of alcohol use disorder globally is more than 13% in men. And this is another very important early warning sign. If we're starting to see a slight increase in the consumption of alcohol, maybe that's an indicator of something else.
And I'm wondering, as you're talking, like we're using the term men quite, generally. Are there nuances around the various populations that we should touch on? Because, not all men are going to present and come from the same kind of lived experience and backgrounds and understanding of themselves.
Yeah, I mean, there's certainly a social and demographic determinants that we need to be considering. When we look at literature from depression, and when we look at suicide literature, there is certainly a disproportionate vulnerability to particular groups, even within that gendered grouping or the sex-based grouping. We know that people who are coming from lower socioeconomic backgrounds are more prone to negative mental health sequelae or a higher risk of suicide. We know migration is a risk for mental disorders and that migrants struggle to access mental health care. It's well known that the Indigenous community has struggled with engaging with the more westernized models of mental health care, and Indigenous individuals, particularly Indigenous men, do struggle with access barriers. So across our socio-demographic groups, across the lifespan, there is a variation within the vulnerability. Young men struggle to access care. Older men are overrepresented in the statistics for death by suicide as well. So we're using men broadly. We're referring to this maybe more from a gendered lens than a sex assigned at birth lens, but there are certainly nuances and cultural demographic differences that do need to be taken into consideration.
And what about the like kind of ages and stages? Like, are there hormonal shifts that can be a key time when certain maybe acute illnesses might present themselves that, it's just good to kind of have as a timeline to be aware of as well.
Yeah, look, mental health is complex, and I think taking a multifaceted approach of understanding mental illness and vulnerability is probably most likely to yield benefit. The singular lens of understanding mental illness, whether it's biologically based or through hormonals, is
Mm.
probably not going to be reflective of
Yeah.
the illness process. But certainly life events are important, and I think vulnerability is important. So when we take a biological, psychological, social, multifaceted approach, biological vulnerability is certainly something that needs to be considered. Having a family history in a
Mhm.
first degree relative, a parent, a sibling of a severe mental illness does increase the chances of developing that illness through hereditary pathways. We know that there is intergenerational transmission of disorders like mood disorders, substance use disorders. So paternal substance use disorders increase the risk twofold in the offspring. So genetics certainly plays a role there. Early life is a critical phase, particularly the first 5 years of life. So early life adversity, exposure to trauma can certainly prime the brain and affect the way that the brain develops over time and predispose individuals to developing mental health conditions later. And then life transitions, major life events later over the course of an individual's journey can also lead to the manifestations of illness. It's almost like a perfect storm.
Right.
Vulnerability, early life adversity, and then major life events that often lead to the precipitation of mental disorders. And
And
transitions in life are important.
absolutely. And I was just saying, like, life events could be anything from fatherhood to losing a job to, all those sorts of things that could, trigger and instigate a mental health shift.
Yeah, and we're starting to recognize that more as it relates to men. So, when we look at the literature, there seems to be a disproportionate vulnerability to men in certain life events. So certain transitions seem to hit men a little bit harder than other segments of the population. And key major life events relate to relationship breakdown. So, men who maintain relationships are more protected from depression, less likely to die by suicide. However, men who are going through separation or divorce, particularly in the acute phase right after, have a much higher risk of death by suicide and of mental health consequences like depression and anxiety.
Right.
The
And
other piece that's also very important relates to the loss of employment and retirement, which is also a very key major life event that disproportionately affects men. So men who are in sustained employment of a higher socioeconomic strata tend to be protected from things like depression, and those who are losing their employment or struggling financially are at a higher risk of death by suicide. So these are key life transitions, major life events that should prime us to start to think about vulnerability, particularly as they relate to men. It's interesting, Donna, that you mentioned fatherhood. And I think that that's something that's getting a lot of attention, rightfully so, in the recent past.
mhm.
I'll speak from my own lived experience. I've got two very young children, a 3-year-old and a 2-year-old,
Oh,
and I
you're
don't think
busy.
and I don't think anything could have prepared me for that transition from maybe being a little bit more singular, operating within a relationship to then having dependence and juggling that with social expectations, expectations with your employer, occupation, and otherwise. And I think that that's reflected in the literature too. So men who are approaching fatherhood and in the 1 to 2 years after becoming fathers can have rates of depression as high as 20 to 30%. And that
Wow.
wasn't recognized earlier and is becoming increasingly more recognized now. It's another vulnerable period that I think we need to be paying a little bit more attention to.
So there's obviously lots of moments when accessing mental health care and supports would be enormously beneficial. What are the obstacles? Like we've talked about stigma. Can you dig a little bit more into that? Like what is preventing our men from seeking the support that is there for them?
Yeah, I think it's a really good question and kind of like the million-dollar question. I wish I had
Right.
a straightforward answer for you.
And
Again,
different for so many individuals, but like let's, kind of dive in a bit.
100%. And I think this is also multifaceted. I think we'd have to look at this at an individual level, at a social level, at a structural level. We talked a little bit earlier about the way that men are conditioned to understand and interpret distress, from a stoic
Hmm.
perspective, self-reliance. Seeking support is a sign of weakness. That at an individual level plays into self-stigma, right? So the way that we conceptualize self-care as not being masculine is something that needs to be addressed right at the offset. I think these attitudes at an individual level are significant barriers to access to care. The other piece is the network that men are existing in, the peer network surrounded by other males who probably have a very similar perspective when it comes to mental health, emotional distress. Are they equipped with the literacy to be able to recognize, hey, my buddy here is struggling. Should I be directing him to go to his physician, or should we go to the pub to just talk about it? How are we recognizing distress and thinking about the pathways to connect somebody with the appropriate kinds of support? And I think that we know from literature that people are more likely to engage in care if they're encouraged to engage in care. And I think that that's something that might be lacking within the peer support networks that men are accessing. And then finally, from a structural perspective, what I'll say is, you know, mental health systems currently may not be geared to meeting men where they are. If you think about
Mm.
a lot of the factors that are probably impacting us at a population level, the fact that appointments are only really available between 9 to 5. I mean, I haven't been able to go to my family doctor for the past 2 years. I haven't gone for an annual health checkup for the past 2 years. So this is something that's probably facing a lot of people that are in sustained employment, and a lot of men are in sustained employment and seeking help, and this is a major, major barrier. The other is extensive wait times. How many people have tried to seek help, but the appointment that they get offered is 2 to 3 months down the road? And the motivation to seek help can change. Things can deteriorate over that period of time. So another key obstacle. One of the other things is maybe gender matching. How are men perceiving who they're going to see when they enter a clinical environment? Am I going to see another male that might recognize or understand what my perspective is, or am I going to meet somebody who won't? And I think all of these are potential structural barriers that are impacting men engaging in care.
And I'm wondering, as a clinician at CAMH, what is happening on the ground there to help, alleviate some of these obstacles?
Well, I think the most important thing is days like today. So knowledge translation, starting the conversation, raising awareness, improving health literacy can do wonders in terms of addressing a lot of the barriers that we've already discussed in terms of access to care. We have an amazing initiative that we're just trying to get off the ground, and you touched on it a little bit earlier as it relates to my role today. We've been given a very generous philanthropic gift to start to build a program of work that addresses men's mental health in Canada. And this program of work is going to try and understand what some of these barriers are to accessing care, but also what are some of the facilitators? What can we do? What can we learn from people with lived experience who have accessed care to modify our services? The other piece of work that we're trying to do is to understand what approaches can be implemented here and now, and where should they be deployed in order to meet men where they are. So we know that men struggle to access care. They might access care in crisis. Should we be thinking about accessible interventions that are deployed across emergency departments, for example? So at an organizational level, we've got a group of people, clinicians and scientists that are hoping to develop a bit of a strategic plan to address a lot of men's mental health needs as they relate to the Canadian population, to build the evidence base to know what works and where it might fit within our existing health systems. And then a lot of what we're doing here today, having conversations to start to get an increase in the awareness, increase in health literacy so people can start to access care a little bit more quickly.
Well, and there's an illness continuum, of course, right? From, acute illness and psychosis to things that are less severe presenting. And I can hear our guests here today like, but how do I start? Like, how do we engage those initial conversations, which can feel awkward and scary, and you kind of know you might be going into some resistance to begin with. How do we start that kind of support?
Yeah, that's again a great question and a million dollar question
Yeah, we
there.
only have 25 minutes. And please, just a reminder to please put your questions in that question box because in about 15 minutes we will be getting to Q&A from everyone.
Donna, I think everything starts with a conversation. And the title of today centers around the fact that a lot of people are suffering in silence. And I think starting with a question of how somebody's doing, if they're stressed, is there something in their life that they're worried about, can be the segue to being able to understand what somebody's circumstance is, and then be able to direct them through the appropriate channels. With the way the health services are laid out, in all honesty, the easiest access point tends to be through our family physicians, access through primary care. But there are a lot of other avenues that exist, counseling services, peer support networks. In an urgent situation, your local emergency department or calling emergency services. But where to start, I think, is a conversation. I think it's checking in with the people around us. I think it's being mindful of these really subtle indicators that something could be brewing, and then thinking about those major life events and how to intervene early and direct people towards healthcare professionals who could hopefully provide some support.
Well, and you mentioned earlier the importance of connection, and it strikes me that it's also worth kind of noting that it's not just one conversation, that it's a series of conversations, and that maintaining that sense of connection can be such a powerful building block that it's not just a one and done kind of thing.
For sure. If we go back to the earlier conversation about how illness may manifest in men, social withdrawal is a key one, right? So if somebody is not responding to you, they're not engaging in the same way that they were before. For me, that's always a little bit of an early warning sign to reach out, to try and connect and see if we can figure out what's going on there.
Well, and I wonder if you can talk a little bit about the impact when individuals, and it is Men's Mental Health Month, so we're, talking specifically about our men. What is the impact when we don't get the mental health support that we need? Like, how does it impact us as a society? Because it is more than just an individual um, crisis, right?
Yeah, look, you've said it before, and I think connectedness is key here. We don't exist in isolation in our society, right? Men in our society are fathers, they're brothers, they're somebody's son, they're your friend, they're your colleague. And I think one of the most visible societal consequences is the loss of life. We're talking about the huge overrepresentation in mortality figures here of men who are not accessing care. And like I said before, mental illness is treatable. We need to be able to recognize who these folks are, get them in front of a healthcare professional so we can try and avert a negative outcome. So for me, the most stark, the most alarming consequence is the loss of a father, the loss of a husband, the loss of a son. The other aspects that I think are important to consider at a societal level are economic costs. This is beyond just an individual level, but at a societal level. These are direct costs of ill mental health, accessing community services, inpatient services, emergency services. What about the costs incurred by people who are no longer productive because they have a chronic illness that maybe wouldn't have reached a chronic stage had we intervened early enough? I mentioned that we don't exist in isolation. The whole family system is impacted by the ill health of one of the family members. So if that's the father, the sibling, the son, there is a consequential impact. And when you look at the literature and you compare severe mental disorders, I'm a schizophrenia guy. When we look at schizophrenia, the impact of schizophrenia on the family system outweighs the impact of other chronic disorders like cancers. These are
Wow.
incredibly burdensome conditions. So the whole family system is affected. I mentioned the intergenerational impact. So we were speaking about substance use, we're talking about hereditary transmission. That's another significant impact. Substance use disorders that go untreated, a twofold increase in the offspring. Um, Intimate partner violence is associated with untreated mental health conditions. Within
Mm.
our populations that are facing homelessness, within our populations that are engaging with the criminal justice system, there is a humongous overrepresentation of people with substance and mental health conditions. So these are all wider, far-reaching consequences of untreated mental health that extend far, far beyond the individual and the family system and really impact every one of us.
You mentioned something so simple and so powerful that I'd like to go back to is you said mental health is treatable. And I'm wondering if you can expand on that a little bit because I think there's a lot of maybe intimidation or people just don't know what they're signing up for. And obviously, there's a continuum of care. It's not going to look the same for everyone. But can you demystify that and kind of reassure us a little bit? Like when you say mental health is treatable, what do you mean by that?
So look, it depends across the diagnostic spectrum what we're talking about and what the outcomes will be. We use this blanket mental health to define a whole host of different conditions that have different kinds of trajectories and different kinds of implications, just like physical health conditions, right? Um, Broadly speaking, we have effective treatments across the diagnostic spectrum, whether we're talking about schizophrenia, whether we're talking about depression, bipolar disorder, or anxiety disorders. And the treatments that are available are a combination of things. Medications are certainly very, very effective, and for the more severe end of the spectrum, are critical cornerstones of treatment. However, at the very early stages, medication may not be indicated. You know, Support from a social perspective, psychological support through therapy could be the indicated treatment. programming through school could be the appropriate treatment. So I think it depends on where in the continuum one is, what the
Mhm.
disorder is, in order to determine what the effective treatment is. But there are lots of different modalities, and we have a lot of different options, and those options do make a difference. People's symptoms get better, their functioning improves, and most importantly, their quality of life improves.
Well, and going back to some of your research a little bit, because men start as youth and boys, and I'm curious about some of the work you do with art and film and how representations in our world kind of help shape the stigma and the situation we're in. What can you tell us about how to support our boys and young men, or young youth, sorry, in terms of setting themselves up for success with mental health?
Yeah, look, I think that the solution has to be a multi-component, coordinated solution across the lifespan. Yeah, I talked about the early stages of life and the vulnerability in that first 0 to 5 years. There isn't enough emphasis on that vulnerability to new parents that are coming in to take the
Yeah.
role. It's such a stressful life transition for men, for women, for anybody who's taking the role of a primary caregiver. And we don't do enough to equip people with the skills to be able to have healthy attachments with their children,
Yeah.
to look after their own mental health and engage in self-care, because you're only as good as a parent as well you can be, right? To be available for them. So I think that parent-child interaction training, thinking about parenting skills are critical in that early stage of life. Positive experiences early in life are incredibly important. We know that adverse life events early can really predispose people to mental health conditions later in life. So promoting, communication, safety within the environment at home, making sure that we're modeling resilient behaviors. And a lot of that also comes from understanding what these resilient behaviors are. All of those things can have a key impact, particularly in the early stages of life. I think when it comes to, our youth and young adults, school is probably one of the most scalable platforms where we can reach boys, our young men, teach them about social skills, emotional skills, and how you can promote positive emotions and social skills. We know that those sorts of interventions can reduce the risk of mental illness. They can improve functioning. They can improve academic performance. So certainly across the lifespan, there is an importance to start to instill a concerted effort to build skills that may hopefully enhance resilience and prevent the progression to more severe outcomes. Later in adolescence, particularly as it relates to boys and young men, I do worry that if we're not thinking about male relevant settings, like, you
Mm.
know, thinking about where they're accessing support, where they're engaging, sports clubs, fitness centers, like embedding mental health literacy and mental health interventions within those contexts will probably be very helpful in terms of addressing mental health issues very, very early in life.
We're soon going to move to the Q&A portion, so just a couple of more questions now. We have people joining us today, Dr. Hussein, from all across the country. So resources are going to vary dramatically depending on where people are. Where do we go? I've watched this webinar and I want to find resources for myself, for my loved ones. Where are some of the places to go?
Particularly for young people, there's been a national drive to have youth mental health hubs across the country. So youth mental health hubs, if they're available in your region, are probably an excellent place for our younger population. Regardless, if there is access to a family physician, that's probably the entry point for any one of us into any a discipline of medicine to seek support. So when it comes to mental health, if there are concerns, contacting your primary care physician, thinking about what the resources are available, because they'll know how to navigate that local sector better than anybody else will. Counseling resources, again, looking at what's available locally, jumping onto things like Psychology Today, that's a national online platform. Thinking about where therapists are within your proximity is also an exceptional guide to being able to access care. In urban settings, I think it tends to be a little bit easier. You can always go to your local hospital if you're concerned. In the event of an emergency, I said this a little bit earlier, there is no better option than going to your nearest emergency department and calling emergency services if we are concerned about somebody's safety and well-being. But that can also be an access point if all other options fail as a last resort. We're concerned about mental health. We've tried everything else. We don't know what to do, and we're concerned about our loved ones. Our website, the CAMH website, has a huge number of tools. We have a family resource center that's a very, very informative that can help to guide health service navigation. And then for people who are in our local catchment, we have very low barrier access when it comes to mental health within the CAMH site. So if in doubt, always come there.
And there's a toolkit that will be sent out to everyone that's here today or that registered with a lot of those resources in it as well. Dr. Hussein, we've talked about some very scary, very grim statistics and situations, but I'd love to end on something a little more positive. And if you could share in your clinical time, in your research, what is making you optimistic about men and mental health? What is giving you and hopefully the rest of us some hope about the future?
Look, I work in probably some of the most acute settings. As a psychiatrist, I'm day to day on an inpatient unit where I see the most severe end of the spectrum, particularly in young people in the early course of illness. And these young people get better. We manage their symptoms, we reduce their distress, their functioning improves, and like I said before, quality of life improves. So we know that we've got the tools at our disposal that will improve outcomes in the patients that we're trying to treat. And that's what gives me optimism every single day from a practicing frontline clinician. I work in the emergency department. I see people come in with thoughts of suicide, and coming and seeking help is the first step to being able to avert that negative outcome of a death by suicide. So we do life-saving work every single day here at CAMH, and nothing gives me more optimism than seeing patients get better. From a research perspective, what I'll say is that initiatives like the one that I'm describing, where we've got incredibly generous donors that are helping us to address a lot of the gaps in knowledge, to invest in clinical research, which is so essential for us to be able to inform a better understanding of these very complex conditions and how better to treat them. That gives me a great sense of optimism. We're moving the needle slowly, but it's like a magnificent sculpture. You chip away at it slowly, and eventually you get the masterpiece. And I think that that's what we're doing at our center and other centers like ours internationally. If anything, we could have learned from the COVID-19 pandemic is that a concerted, collaborated effort can really lead to magnificent changes. So all of those things, I think, leave me with a lot of optimism.
The symptoms can get better. That's such a powerful thing to hear. I'm going to move to the Q&A now. Pardon me. And we've had a lot of this similar theme come in, Dr. Hussein. So I want to, just really acknowledge that a lot of people are feeling this way. And the first part of the question is, how do you help someone who doesn't believe they have a problem that requires help, that there's resistance in that even initial conversation of seeking support and services?
Yeah, I encounter that on a day-to-day basis. So like I said, I work within the psychosis space. I work within the schizophrenia division. A lot of the patients that I see aren't aware that they're unwell. And unfortunately, that serves as a significant barrier in us being able to intervene early. um, a lot of the pathways to access are dependent on their family members and loved ones who bring them to the attention of services, as opposed to waiting for the individual to access care themselves. So a lot of the times, family members, friends, carers, loved ones in the community are our partners in care that are bringing patients to the attention of services. It's difficult. I think it needs to start with the first conversation and then revisiting that sensitively over time. Where possible, bringing in somebody who they trust, who they have rapport with, to see if they can get in their ear and try and encourage them to go and see their family physician. Think about coming into a walk-in clinic, or seeing a therapist is usually the first step. In some instances, to be honest, there are no options but calling emergency services or taking somebody to an emergency department, because things get so concerning or so severe, that there aren't any other options left. So it is difficult. Unfortunately, it's something that we need to kind of persist with and try and keep on chipping away at.
Well, and because people are, talking about wanting to maintain the autonomy of their loved one and that the conversations just never feel like they're going anywhere. And I'm wondering if you can touch on just briefly the mental health impact of the caregiver in those situations, because that can be a very heavy emotional weight to see your loved one kind of spiraling and not wanting to maintain connection and their autonomy without being, too forceful about what they need.
Yeah, I think, balancing what the role and the responsibility there is always an area of tension. The loved one there isn't the clinician. It shouldn't really be their job to take the horse to water, so to speak. But it's equally very, very challenging to be able to see somebody in distress, to see somebody struggling with their functioning, to see somebody who is not fulfilling their potential. So there is a significant amount of care burden. I mentioned this before. It's not surprising that severe mental health conditions have more burden on the family than other comparable conditions like cancers. It's because it's very, very difficult to see. And a lot of the times, the person who's affected either doesn't have the motivation, and in some cases, they don't have the insight to be able to seek help themselves. So the onus, unfortunately, does land on the loved ones around them to try and shepherd them towards the appropriate care pathways. Um, I wish I had again like a silver bullet here, but I think persistence pays off. I think that leveraging relationships and engaging people who are trusted and who may be able to lend support and encourage the individual to seek help is always worth trying.
I'm going to even narrow that down because the family dynamics is something that's coming up a lot in the questions. People are, have tried to raise the topic with fathers, brothers, friends, partners, and it's being met with anger as a reaction. So, how should we think about anger as part of our emotional well-being, and what are some, practical ways to respond to it, whether rather than just react to it, because the wall can be so forceful.
Yeah, I think that that's an important cue as well, for the individual who's trying to encourage the person to seek support, that maybe their readiness isn't there. For me, that's always an indicator of gently disengaging and revisiting at a later stage sensitively, or asking somebody else to potentially do so, directing them to a family physician for other concerns, and hopefully alerting them to issues that you've observed, and maybe that person can take the responsibility of trying to engage them with services. We talked about men having externalizing features, that irritability and aggression can sometimes be a feature of mental health. We also need to be mindful of what is safety and what is not going to be safe when we're trying to encourage people to access care. So if there is hostility, if there is a lot of resistance, the cue there is to just take a step away and ensure that there is personal safety. And again, if there are concerns that things are escalating and the individual is unsafe or members of the public are unsafe, for me, that's enough reason to call emergency services and think about going to your nearest emergency department for an assessment.
Again, family dynamics being so unique and powerful in this conversation. We've had, parents asking questions about having adult sons. Some that are living with depression in different ways. One is using substances as a way to cope, another is struggling to maintain work, and there's a lot of hopelessness with everyone within the family. So, what advice would you offer parents and caregivers who are trying to support adult children with significant mental health challenges while also coping with their own feelings of worry and guilt and helplessness?
Yeah, again, the tension here is really, really difficult to manage. And I empathize a lot with caregivers, loved ones who are trying to navigate a very complex
Mm,
health system as it is.
yeah.
But in relation to somebody who's not ready to seek care, I think that the balance between individual autonomy and trying to gently encourage is important to strike. I would say that the encouragement should continue where possible and safe to do so. If we're starting to see that um, there is an escalation in irritability, anger, or a safety concern, I think that that's a very clear warning sign to take a step back and think about whether or not there are other routes that should be explored. Like I said, through primary care, maybe even thinking about emergency resources through emergency departments, like our emergency department at CAMH. Um, it is a difficult situation that doesn't necessarily have a clear answer, but I think ongoing dialogue and pulling in people within the community, people who are trusted, looping in the family physician, thinking about if there's a therapist or a social worker involved, is always the best approach.
There's also a lot of concern with something that is very contemporary for our world right now around online communities and content, the manosphere that reinforces isolating, stigmatizing ideas of masculinity. So, for young men and older men who may be drawn to these spaces because they are seeking that connection, that purpose, those answers that are so craved for their struggles, how can families and communities and mental health professionals engage with them in a constructive way? Like, what are some of the most effective ways in fostering healthy forms of masculinity and belonging when we have so many men seeking that so desperately?
Yeah, look, I'm always a little bit careful when it comes to these concepts of toxic masculinity, the manosphere, the messages that people are receiving. Um, there are some people who could benefit from that social connectedness, and the absence of that may struggle with a lot of social isolation, a lot of hopelessness. So in some cases, it may not necessarily be as problematic as we may think. Um, People have taken a more nuanced approach to understanding the digital space and how people across the lifespan are interacting with it. I think that this needs to be more of an education approach that begins early over the course of life. I think again, schools need to be talking about digital literacy, potential harms and benefits that may face people. Um, it is challenging at this stage to have any blanket approaches to addressing this. I know Australia has certainly taken a stance where they're banning access to social media for particular age groups. The US has a slightly different approach, and I think North America is taking more of a nuanced approach, which is probably more reflective of the complexities. Um, Engaging people is important. Trying to get folks to socialize is important. Getting folks to try and seek help when they're ready to seek help and trying to enhance motivation, I think, is the key message here. And hopefully the readiness will come over time. It's very difficult to minimize the exposure of any of us to what's available out there in this, a wide digital space. And certainly vulnerable people are drawn to certain kinds of messaging that does um, promote some sorts of some fringe ideologies that can be problematic.
We have another question that's come in, which I can only imagine how hard it is for this individual. But we're hearing from people who have experienced a mental health crisis and are trying to access a psychological assessment, and there's just delays and uncertainty around referrals and next steps. So for individuals who are seeking help but feel stuck in navigating the system, what advice would you have? And do you have any thoughts on how to advocate for themselves and what are some realistic expectations, noting that the country is very big and there's very big different resources or like for everyone, but what are some key advocacy tools that we can be using and just some thoughts around navigating the system when you just feel it's not working fast enough?
Yeah, look, I think that this is probably reflective of our health systems broadly that are underfunded, under-resourced, and I think this is far more far more evident within our mental health services nationally. So wait times, as I mentioned earlier, that's a key barrier to access that affects all of us, and particularly men. That is an issue that I think strategically is very, very difficult to address until we have some sort of a strategic policy directive that allows for a shift in the investment to make sure that our services are adequately staffed so we can address a lot of these wait time issues and these system level barriers that are impacting people's access to care. What I would say at a local level, reaching out to our counselors, our local ministers is important. Writing letters, and starting to raise the issue is critical. That's where advocacy starts. And I would encourage anybody. I also tell people to complain. You know, complain to your local programs that actually, you know, my son, my loved one, my husband has been waiting for months and we're continuing to be concerned. It's not good enough. We're all taxpayers, and I think that we warrant access to timely interventions. So I think that it's important to try and to raise the issue wherever possible to our local constituencies.
The Canadian sternly worded letter always has a place, and the squeaky wheel gets the grease sometimes, right? Um, Another really interesting question around, we know that there is stigma is a significant barrier, as we've talked about today. When it comes to seeking mental health support, statistically, we know men are highly unlikely to seek that professional support. So, as communities look to create spaces where young men can connect in friendship based on shared tasks, whether through sports or hobbies or mentorship, how can we thoughtfully incorporate evidence-based mental health tools in supports into these environments so that our networks in a way that they feel more approachable and accessible?
Yeah, this is a key directive of clinical research internationally at the moment, where we're starting to think about what we can deploy within settings like sports clubs, fitness centers, places where men are accessing any kind of social engagement, and can we start to implement some strategies within those contexts to enhance literacy, build skills, trying to get people engaged in the right kinds of support. I do think that framing is important, and I think credible male messengers are also incredibly important. As a part of our work, we're thinking about leveraging, you know, respected, credible male figures, sports stars, athletes, people who could start to give a little bit of a different message to men, particularly as it relates to self-care. You know, I talked earlier about this stoic, self-reliant approach and interpreting seeking help as a weakness. That needs to shift massively. We need to disentangle self-care being an unmasculine thing to embedding it within masculinity. So I think that those are some of the broader strategies that need to be deployed. Certainly, as a part of the work packages that we're going to build out in our program over the next few years, we're going to be thinking about interventions that can be deployed across diagnoses so that we're not excluding people and we're not trying to pigeonhole them into a particular disorder to give them access to care. How do we have these transdiagnostic, diagnostic, agnostic approaches to trying to improve outcomes in people? And I think that that's the move internationally from a clinical research perspective.
Someone is asking about how they can communicate. So they have a loved one who's had a crisis but is doing much better. So, for the loved ones in those situations, how can they check in and sort of see how someone's doing without seeming like they're undermining their experiences or their recovery without being intrusive? What are some helpful ways to start that conversation and continue it over time, so you're not in the crisis moment anymore, you're kind of in a maintenance connection kind of way?
I think even just being socially engaged and making sure that there's connectedness and contact and some degree of observation about how somebody's doing can be really reassuring. We talked about some of these really subtle indicators, right? So when it comes to deteriorating mental health, sometimes those subtle indicators can be social withdrawal. It can be that somebody's not working in the same way that they were. It can be that they're not attending meetings, get-togethers, birthdays, maybe a bit more irritability, some risk-taking behavior is starting to develop. You know what? They never used to have 2 or 3 drinks a night. Now they're having more and more. All of those observations can sometimes be helpful. to reassuring you whether or not somebody's on track. And if we're starting to see things that are concerning, just a gentle confrontation about how things are going. Somebody's feeling stressed. Have they connected with somebody to just to check in and see if things are maintained or maybe something needs to be modified? The balance of overstepping and being almost a bit paternalistic is challenging, and I do think that there's a tension between that. For me, sometimes the easiest way is just to remain connected and encourage people to access care through the appropriate channels. Because when somebody's gone through a crisis, usually they've accessed some sort of professional help. To continuing to encourage them to engage with that over the longer term is sometimes the best advice.
And starting that connection before you kind of realize that there might even be a crisis. Like the corollary is it's never a bad time to just check in and say, "Hey, how you doing?" Like even if you're not seeing an issue.
Always, always.
So we've got two more questions, Dr. Hussein. One is a question around financial barriers. So, someone who is experiencing depression, they're currently unemployed, so they don't have insurance. They want to seek resources, but there is a financial barrier. For people facing that, what options are there or supports that are available, and where would you recommend they start?
I think that because of the variability geographically with regards to access to resources, sometimes an internet search is probably the best way to being able to determine what is available. As far as Ontario Health goes, there are some resources that are covered by OHIP. Now, their wait lists tend to be a little bit longer, but simply searching OHIP covered counseling, OHIP covered therapy can sometimes be the easiest way. A lot of institutions actually have on the internet information guides in terms of accessing therapy, in terms of accessing mental health supports. I directed you folks to the CAMH website. There's a great resource, family resource center that's available at CAMH as well for folks who are within the GTA. But I think that jumping on online and starting to look at what are the OHIP covered or health insurance covered programs that are available is probably the best way to go. If in doubt, family physicians are really well equipped to being able to navigate services locally. They sometimes within their health centers have access to mental health providers, and that's also another very important resource to be able to access.
And some providers have sliding scales, like it never hurts to ask those questions as well, right?
Certainly, certainly.
So we're going to, this is our final question today, and then we're going to wrap up. But we've talked about the barriers to care and care access and signs of needing help and the importance of opening up conversations. As we close out today, if you could tell us one practical step that we can take this week to create more mentally healthy and supportive environments within our home, within our workplace, in our communities, what's one gem that we could all start today with?
Yeah, I think maybe avoiding any kind of stigmatizing terminology. We're talking about the
Yes.
themes that have come out today are the individual that is seeking help is reluctant to seek help. Maybe starting to focus the message on something a little bit simpler, focusing on tangible benefits like, hey, like maybe getting out and seeing your friends would be something that would make you a little bit happier. Hey, maybe thinking about some part-time work would make you a little bit happier. Getting back to the gym, some tangible functional gains, maybe the segue to being able to figure out what the individual goals are there for the person who's affected. And then that could be the springboard to thinking about how we can get the right kind of support around them. So that might be the easiest starting point.
I love that. Well, thank you so much, Dr. Hussein, for spending so much time with us today. You're obviously a very busy guy, so thank you so much for your generosity and your expertise today. Thank you to everyone who joined us today. We really appreciate you taking time out of your day today. And of course, there is a village of people behind the scenes that make these webinars possible. So thank you very much today as well. Conversations like this can bring up all sorts of things. Maybe you feel a little closer to someone in your life right now, or you feel like you recognize something in yourself or a loved one a little bit differently or with a little bit more clarity. Whatever brought you here today, we hope that you are feeling a little more supported, a little clearer about where to go for resources, and that toolkit and the recording of today's webinar will be coming to you. If today's conversation resonated with you and you believe in the importance of expanding access to evidence-based mental health care for men and boys, there's always a next step, and every gift to CAMH helps ensure more men get the care that they deserve earlier and before crisis. CAMH is here to ensure that no one is left behind. Before you go, there's one more little thing that makes it so helpful to us. There'll be a quick survey that pops up. If you could please take a couple of minutes to fill that out, it really helps these webinars be more targeted and exactly what you are looking for. So if you could please take a minute before you sign off and complete that, that would be so appreciated. Thank you again for being here today on behalf of everyone at CAMH. Thank you so much. Take care and have a wonderful day.